Well, in essence, what we are presenting is the clinical endeavors that has been carried out in the last 2.5 years. Since in 2004 was discovered for a new mutation in a subgroup of lung cancer patients that is on the gene that is called EGFR. And overexpression of EGFR is very common in tumors. You know that for this reason, EGFR inhibitors were developed, gefitinib, Iressa, or erlotinib, Tarceva, and still the degree of efficacy of these oral drugs was rather limited when administered in general in patients with advanced non-small cell lung cancer patients. Until now, the approval of erlotinib is in second line as the level of efficacy is short-lived responses, but similar what can be obtained with second-line chemotherapy. What was the impact of this is that in 2004, EGFR mutation was described mainly in non-smokers and females, adenocarcinoma, Asian patients. The following speaker, Dr. Tony Mock, will illustrate the impressive experience in Asia. And taking this into account, you can see that other gene mutations that were described in CML, in chronic myeloid leukemia, were dramatically responding to other oral inhibitors like imatinib, or gastrointestinal stromal tumors also respond to imatinib or Gleevec. Taking into account this information, and since there is preclinical strong evidence that this is a unique mutation that can cause cancer, at least in animals, in mouse model, this mutation is able by itself to cause lung cancer, and that can be abrogated with the use of erlotinib. For instance, we carry out this prospective study in patients with non-small cell lung cancer having this mutation. In total, we have analyzed more than 300 patients with EGFR mutations. We are presenting update data on the first 191 patients. You can see for the first time with a single pill, daily pill, in patients with brain, bone, liver, etc. metastasis, they can attain response, even complete response in a small fraction of these patients that I will show later. And time to progression was 1 year. Overall median survival is 22 months. But specifically, patients with good performance status, that is involved, meaning in the 1/3 of the patients have good performance status, still longer survival are attained in female. There are two main mutations. One is happens in 2/3 of these patients, that is a deletion in exon 19 of the gene, and also the absence of brain metastasis have even much better outcome in terms of time to progression and survival. And even in some subgroups, median survival has not been yet attained. This is for this we are trying to stress the fact that this is a new landmark in cancer. Of course, the discovery is not our discovery. It's our clinical endeavors that we need. We believe that this, in comparison with the majority of lung cancer of smokers, without these EGFR mutations, you can see at the bottom, response rate is rather limited, 30%. Time to progression is 5 months, and median survival is 11 months. I will stress that the assessment of EGFR mutation is quite relatively rapid in 8 days. I am refraining. I will ask for questions, because not always patients who we can suspect that they have this kind of tumor, we have not tumor tissue available, and we are also able to find this mutation in the circulating serum or plasma, in the circulating tumor DNA. In essence, more than the majority of hospitals, that were 130, were from Spain, from the Spanish lung cancer group. I illustrate here that we received samples for anecdotal cases for other countries. And we screened more than 2,300 patients. You can hear the main characteristics in blue. You can see 227 cases were in female, They represent 30% of the female that were screened for EGFR mutations. You can look the smoking status. The vast majority of these mutations are found in lung cancer of non-smokers, and we have a relatively meaningful number in terms of numbers. You can see this never smokers, almost 40% in patients from Western countries, in this case from Spain, have this mutation. Also, when we look the histology, as is well known, is 17% in adenocarcinomas, but also in a subvariety of adenocarcinoma, that is bronchoalveolar carcinoma BAC. Also, it's feasible to find in other histologies that are unspecified, and they are labeled as large cell carcinoma. Just to make this very short and just to conclude, the impact that we know of the performance status at the time of diagnosis is also very dramatic. We know that, for instance, in the majority of lung cancer without EGFR mutations, at the time of diagnosis with advanced disease, with a poor performance status, that means that the patient remains in the bed for the significant part of the day. The time to progression is very short, 2 months, and you can look at the bottom. In patients who have the deletion in exon 19, the median survival was 26 months in this very poor population, 23 in very relatively good performance status, but you can see still a meaningful group, a small number of patients with perfect performance status and not reached is the median survival. You can see in blue. And also at the bottom, I illustrate that a slightly better outcome can be attained in female in comparison with men. But in general, this is a new landmark of outcome because we can repeat in blue. We have, for the first time with a single pill, we can attain complete responses in this disease, or we can identify a subgroup of patients. We believe that is a different disease. There is still several controversies in what is the best way appropriate. Of course, it's a prognostic and predictive marker, EGFR mutations, since these mutations identify a different kind of lung cancer for the first time, a molecularly defined disease. For the first time in lung cancer, we have a useful predictive marker, and you can see even in second line, because we treated patients we received patients who have been previously treated with chemo, you can see still in the blue line that median survival is not attained. Also, like a paradigm in the first line, and you look the broken line, this means that there were a small group of patients who had no response, that were labeled stable disease, SD, and this group of patients in first line, median survival is not attained. The only unfavorable group is the uncommon patients, less than 10%, that in spite of having sensitive EGFR mutations, did not respond at all and make a progression, and this is a new challenge of research that could be clarified quite quickly. Therefore, we confirm that from clinical endeavors are very important, very fruitful, and cooperative lung cancer groups. Now also in this, during this meeting, more than 20 European lung cancer groups will just make a meeting just to look how we can organize in a better way to have more just to expedite matters in a more efficient way for the sake of patients and families. Therefore, the discovery of EGFR mutations have to be just put in the clinical setting, in the daily clinical setting. This is feasible. There is no excuse just not to test for these mutations. We know that technologically involves some complexity. Nowadays, with all the courier, the FedEx systems, we can receive, many labs can receive this kind of samples for quickly testing. And we believe that testing and customizing erlotinib is the first step to a dramatic improvement in subgroups of patients. We cannot dream just to provide great expectative for the majority of lung cancer patients, but this is one example that you can identify a subgroup of patients that obviously at the time of progression, these patients are treated with chemotherapy, then are retreated with erlotinib, with new drugs, but this is for the time for questions. Thank you for your hearing this presentation.